I'm Arthur Winter, I'm a radiologist at SCP practice. I have a special interest in interventional radiology. The longer you've been in the game and the older you get, your outlook changes, because when you're in training, you're so focused on making the diagnosis, getting the right answer. You've got to pass your exam, and you've got to do the correct study and get the right answer. But when you're in the game long enough, you realize at the end of the day, it's all about the patient. It's not about getting the right diagnosis. Getting the right diagnosis is important because it's important for the patient. Getting the right diagnosis to the physician is important for the physician, but it's important because it's good for the patient. And so I think more and more, if we focus on the fact that if we're doing it for the benefit of the patient, then we'll automatically be doing the right study. We'll be getting the right diagnosis. We'll communicate information to the patient and to the physician, and we'll help the physician help the patient. So I think the more you do medicine, the more you realize that by helping the patient, that's your primary goal, and then everything else falls into place. Patient is typically referred for cancer diagnosis either as a screening, where a patient may not have any symptoms, and a classic example would be mammography, just because breast cancer is so common. Or a patient can be referred because there are suggestive symptoms, like a patient might have a gastrointestinal bleed, a patient might have weight loss, a patient might have some pain that they cannot explain. And the patient is at high risk in a high-risk age, and therefore the patient will be sent for the relevant diagnostic test.
Hi, my name is Prashna Naidoo. I am a diagnostic radiographer at SCP Radiology. When they arrive, we will fetch the patient, and you'll be asked to change into a gown, and we will go through a series of questions with you. This is to ensure that it is safe for you to receive the procedure. Once we are done with that, we will receive signed consent from you so that it is safe, knowing that it is safe for you to continue. We will explain everything in detail to the patient so that they know what to expect, and even aftercare for the patient.
We use all the range of tests to diagnose these patients. We use MRI, CT, plain film X-rays more as a screening test, and then we use ultrasound. Those are the modalities we generally use. There are other modalities such as PET-CT, which is also isotope studies that we do to try and be more accurate with the diagnosis. But we use the full range of radiological diagnostic modalities. So to know whether a test is diagnostic and accurate and whether it needs to be repeated, you have to look at what are you looking for. For instance, if you're looking for breast cancer and you're doing mammography, it's a screening test. If you find nothing, it doesn't mean that there's absolutely nothing. There are tiny lesions that are not visible yet, but are there. And if you follow them up in a year's time, you might see something slowly growing, and then in retrospect you see, okay, that thing that looked completely innocent is something that's enlarging, and now you've picked it up still at an early stage. So there are always cases that you're not going to see the problem, and therefore you must follow up. Or if you have symptoms that you cannot explain and you do a test, you might see nothing at first. It doesn't mean that there is nothing. The patient does have symptoms. You still got to get to the bottom of that. Then you can do other tests, or you can correlate with blood tests, and then decide based on that what is the next modality you should use to be looking for something. So it often depends on your index of suspicion. Do you expect to find something? then you go looking for it. If you expect to find nothing and you see nothing, then you're happy, then you needn't do any follow-up. So it depends on what the clinical presentation is, what the patient's symptoms are, what you're going to find. But it doesn't mean that these things are 100% accurate. You're going to find the cancer. You still got to go looking for it, and you must know what you're looking for and what it looks like.
When it comes to safety, it is necessary for us to ask the patient certain questions. If it is safe for them to receive an IV contrast, if there is any allergies, or even if they are receiving an MRI, if they have any implants in their body. These things are necessary to ask, as it can cause complications during the exam. In terms of comfort, it is necessary to communicate with the patient so that we can make them as comfortable as possible, and also to ease any sort of anxiety they have or any pain. It is important that we explain to them from the onset what is expected from them and what they can also expect during the procedure. Most of the time, cancer patients do require the IV injection, so going through the necessary questions with them and also explain to them what they will feel during this injection is important, so they do not get a shock while on the table. Patient concerns when receiving any sort of imaging is one of the main things is radiation. However, we do adjust our protocol so that it gives you the least amount of radiation. One of the other major concerns is with MRI. A lot of patients are claustrophobic. However, communicating with the patient also during the procedure can really ease them.
You want to know what the role of the imaging in the planning of the treatment. I think it's a crucial role, because firstly, once the oncologist or treating physician knows the diagnosis, they want to know the staging, and they need to do the imaging to get the staging. Once they've got the stage, they can decide from there which is the best modality. Is it chemotherapy? Is it immunotherapy? Is it radiotherapy? Is it surgery? And that is all based on the imaging. Biopsy needs to be done when there's suspicion of diagnosis, but it cannot be confirmed with certainty on an imaging modality. So especially in oncology, if you suspect there's a malignancy, you want to confirm that. If you suspect that it's an infection, you don't need to do a biopsy. You can treat it and follow it up and see that it resolves. So in general, when there's a suspicion that something may be malignant, that's the indication to do a biopsy. Then we have to have a look on the clinical evaluation and all the imaging. Where exactly is this lesion? How safe is it to do biopsy, and what is the ideal technique? And you want to do it minimally invasive. You want to do it without pain or discomfort, and you want to do it safely without causing damage to adjacent tissues or organs. So more and more these biopsies are done by radiologists, because we can do it under image guidance, and because we can see where we're going, we can be very accurate in placement of biopsy needles, for instance, and we can be very accurate in avoiding other organs and vessels. With the imaging that we use, it's more and more accurate, and therefore it's becoming more and more a modality that's used by the radiologists. So the next question is, which radiologists do that, or do all radiologists do biopsies? I think most of us in radiology do biopsies. There are some that are less comfortable, and some are more comfortable. So it all depends on your inclination and your experience and what you prefer to do. But most radiologists can and should be able to do the basic biopsies. But simple biopsies, if you've got something just underneath the skin that you can easily see and feel, and it's easy to get a needle in there, we can all do that. It becomes more complex when you're trying to biopsy something that's in the lung or deep within the liver, and you've got to use more skills to get at it, and we leave those to the interventionally trained radiologists, and so we can get the optimal result. So there's so many different types of procedures. The ablation therapies would generally entail a patient under image guidance, usually with sedation or anesthetic, or with freezing of the tissue, which is a cryoablation. But other patients where we're not treating the cancer itself, but treating the effects of cancer. For instance, if you have a tumor causing a bile duct obstruction, and one can then use intervention to bypass that obstruction of the duct. So there are many such procedures. So management of pain is a crucial part of oncology. Not all our patients have pain, but some have severe pain, and it can be extremely difficult to manage. And it's a team effort between all the oncologist and the radiologist and possibly a surgeon to find the right combination. Because if your basis of pain management is usually on medical with the drugs they use, but the drugs have side effects, and you use them more and more often. So if you can find something that you can add to that, it's beneficial for the patient. And as I said, we can do nerve blocks. For instance, if you have a specific tumor on a nerve, it can be extremely painful. But if you can find a way of blocking the transmission of pain through that nerve, it makes a huge difference. And that's also minimally invasive, because if we know which nerve to target, we can place a needle right next to that nerve. We can inject a bit of local anesthetic to confirm if the nerve is blocked, that the pain goes away, and then we can, in addition to the local anesthetic, we can add a regional alcohol, and we can do something more permanent to that nerve so it doesn't transmit the pain. There are other forms of intervention also in the pain management. It's, for instance, patients with vertebral compression fractures, whether it's now from a malignancy or from osteoporosis. These can be extremely painful. And one can do vertebroplasty, where you place a needle into that bone and you inject a bone cement, which just supports the bone, and it doesn't fix the problem, but it can take a lot of the pain away. And this is done by orthopedic surgeons, for instance, but also by interventional radiologists, depending on who in the area has the expertise. Follow-up is important for all oncology patients, and the modality of the follow-up is dependent on what malignancy and which organ is involved. But as an example of the breast carcinoma patients, they come for annual mammography. Usually the initial tumor has been removed surgically, but remember, these patients are at risk of developing a second malignancy, so they have to have their annual mammogram. And they have other tests as well. They often have a CT of the neck, chest, abdomen and pelvis to look for any signs of metastatic disease, or if there was previous metastatic disease, we want to see, is it stable, is it responding to chemotherapy, has it resolved completely. We need that information. And these patients are followed up for a long time. The longer they stay disease-free, the larger the interval is between scans. And but the follow-up is important. And then the other reason patients come back is they can get complications of the malignancy, and they can get complications of the treatment. And for instance, if a patient has a pleural effusion because of malignancy, they often come to us for drainage of pleural fluid or drainage of abdominal fluid associated with the malignancy, and that can give them symptomatic relief. So the important thing for SCP is to continue on the way we are doing things, because I think we are an excellent practice, and we've developed ways of doing things as the best we can do them to the highest standard, and we need to keep it that way.